Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. Today is Top 10 Tuesday because we are at the last Tuesday of August. That means that I'm going to have a mixed bag of not only coding questions, but also compliance questions. And it is also the 202nd episode of the CodeCast podcast. And I wanted to give some shout out to some people that just really, oh my gosh, just have humbled me this week and really made me feel like, I need to keep doing this forever. So thank you to JENSYER84 on my Apple podcast rating. She just gave me, I'm not sure what it is, but gave me just the most amazing rating, called me a hero in coding. Thank you so much. Faye CPC, same thing, just great information. And Jules 22197 or 22179, sorry, super helpful. But I just, Sheris 520. Thank you guys. I can't even tell you how much I appreciate those ratings. My LinkedIn people, which would be Jonas, Lady, Fami, Sherry, Kim, Norma, Alan, just thank you guys. I just really appreciate all of the support and the love for the CodeCast podcast. Okay, so let's get started. Enough of the mush, but it's very fun to be mushy sometimes. So when we get into some of the top 10, I want to talk about some things that have come up that probably just need a little bit of review. I think we've had some confusion, especially with, some of the E&M stuff still, and now the shared visits information. We've also had some published reports on the critical care stuff. And so let's just really kind of get back to basics a little bit, and I'm going to give you that with some of the top 10 coding and compliance questions that I have received this week. But first, the CodeCast podcast is also brought to you today by Medisoft Cloud. Medisoft is a cloud-based medical billing system that is fast, highly scalable platform that transforms the way healthcare providers manage revenue cycle management. To try Medisoft Cloud, call MicroWise at 1-800-955-0321 or visit Medisoft247.com. Okay, so let's take a look at some of my questions this week. And actually, it's interesting because a couple of them are, how do I put this? So there's some things as a coder, and let me just be clear on this because I don't want to criticize. I want to be very positive. But as a coder, it is important for you, especially those of you breaking into the coding world. And actually, I shouldn't say that. Those of you that are seasoned coders, there are some things that you need to know and need to make sure that you know like it's secondhand. Otherwise, it could hurt your credibility. And what I'm talking about, one of the things that has come up in the cardiology specialty and the non-coronary, so the peripheral vascular, is something called lithotripsy, shockwave therapy that's being done on the lower extremities by physicians. And the hospital is giving and this is number one, this is the number one of our top 10. The hospital is giving the physicians the code C9766, okay? Now, as a coder, if you are a professional coder, not a facility coder, you should know that that is not, a C code is for the facility. That is not for a physician. It is for usually a device or use of a device. I know we use it, or the hospital uses it, let's say, for 3D imaging on somebody who's getting a heart ablation. It's a facility code that represents, I don't want to say DME, but it does represent not just the service, but also the devices used in that service. And so they actually have an expense, and that's what I was trying to say. The hospitals have an expense, the facilities have an expense that when they submit this code, they get reimbursed for their expense. What we're doing as professional coders on the physician side is that we are billing either procedurally or the professional component. We're billing services that we perform, okay? So if it's in our office setting and we want to get paid for a device, then we would be billing a global service and the codes would be different. But when you see codes like that, the C codes, the D codes, anything like that, that the hospital hands out, you need to instruct your physicians that they are not to be using those. So there was a paper recently written, and I know it's also on Dr. Z's website as well, that the shockwave lithotripsy, let's say for the iliac vessels, that's billed as a PTA or an angioplasty, so 37220. So just make sure that you're aware of that, because that has been my number one question in the last month. My next question has to do with the new split shared visit for critical care services that was on a final document with CMS, and they basically sent out a notification regarding split or shared visits. So number 2 in our top 10, what this refers to. So critical care was never a shareable service in the hospital setting. But split or shared visits in the hospital initial care or the hospital subsequent care actually were able to be shared, and they still are. But now there is a proposed rule for 2022 saying that maybe we will allow qualified healthcare professionals, which are the nurse practitioners and PAs, to share in those services and then bill out under the physician, which I'm kind of surprised, because if they're critical, to me, they should be seeing a physician, but okay. So the confusion here is that split or shared visits have always been hospital-based. Well, I got a question this week that says, so how does this affect us in the office? Well, remember that we've never been able to have split or shared visits in the office before until we had the 2021 rules update for the E&M service for office visits. So now what split or shared in the office means, not critical care, is that if a qualified healthcare provider, again, mid-level provider, and a physician are joining their timed-based visit together, it's not a medical decision, it's on time only, then they would act as one provider. And so in the office, they're allowing that. Well, the question was, can we do that with all new patients? No, you can't. So this is something that if it happens, they're saying we allow for it, but try to be careful as far as utilizing a loophole or some new guideline that would flag you for an audit, and that would. So yes, shared visits are now allowed in the office, and yes, for new or established, but only for time-based services, and it should be the exception, not the rule. So that would be number 2 as we're talking about our top 10. Number 3, again, I'm going to talk about cardiology just a little bit here. Terry, when we have a patient who is having a heart cath, the doctor just says heart cath, and I can't tell if it is the 93458 code or the 93454 code. How do I tell the difference? Okay, so the 93454, and again, 26 modifier if you're not performing it in your own office-based lab or place of service 11, that is for what we call a non-concomitant heart cath, meaning we didn't go into the heart, we didn't cross over the aortic valve, all we did was inject the coronary arteries, and so that is a 93454. If your physician went into the heart, so they crossed over the aortic valve, and then typically they will inject into the left ventricle, they call it an LV gram or a left ventriculography, then you would kind of up your code, if you will, to the 93458, because that code says left heart cath with or without, or should say when performed, the left ventricle injection. Well, what if the left ventricle injection isn't performed, which is what this question alludes to, and they say the same thing within the record? What am I looking for? Okay, so what you're looking for as a coder and as somebody that needs to have a little bit of clinical knowledge, you're looking for pressures. You're looking for something that says LVEDP, left ventricular end diastolic pressures. So what those pressures measure is if the patient is at risk or high risk or medium risk for possible heart failure. And you can't measure those pressures unless you go into the heart. And typically you'll find the patient has elevated ventricular pressure if, that's why they call ejection fraction, if the patient just had an MI or during an acute MI, myocardial infarction. But when you're looking for pressure measurements, and if they did have information there, which either says aortic pressure or left ventricular pressure or LVEDP pressure, anything like that, then you can bill or you can report the 93458 with a 26 modifier without an actual left ventricular injection, because they have to go into the heart, or they should say they have to cross over the aortic valve to go into that area of the heart to be able to even get those pressures. So hopefully that helps on that one. So question number 4 is, it says, Terry, one of the people in my group practice, one of the providers, is a clinical social worker that doesn't usually bill their provided services by E&M codes. However, the social worker is interacting with patients remotely through virtual check-ins during the pandemic. Can we bill E&M codes here? So the answer is no, but we do have a loophole now during the public health emergency. So during the PHE, Medicare had in their FAQ sheet, fee-for-service FAQ sheet, put in something that said that certain practitioners, and they've allowed it under the virtual check-in code, which would be the G2012, have allowed physical therapists, occupational therapists, speech-language pathologists, and yes, licensed clinical social workers and clinical psychologists who do not report E&M codes to bill for virtual check-ins. And remember, that's a code that determines if a patient needs to be seen. So they haven't been seen in the last 7 days, and they're not going to be seen within the next available appointment or in the next week. They also activated certain CPT codes 98966 to 98968, which describe assessment and management services over the phone for those same providers. So it's during the PHE. I'm positive that those services are going to be closed or cut off as soon as the PHE ends, which I'm assuming is probably going to be in 2022, just because of the Delta variant. But it is a loophole, and make sure that those services are medically necessary. So no matter what, just because we have that loophole doesn't necessarily mean that you should be billing it, which leads me to question number 5. So, you know that I've been very vocal about the OIG work plan for dermatologists and billing for an office visit on the same day as a minor procedure. Well, for right now, especially with the surge in the variant of COVID, it might be helpful if you talk to your physicians about, especially derm. If there's a patient that they're not sure if they need to have a removal today, and they feel they need to do either a total body exam or biopsy or a shave biopsy or a punch biopsy, if they feel that there's a possibility but they don't know until they examine them, if there's a way that they can do it in a virtual setting, since we're still under the public health emergency, and then if they feel based on that audio and video visit, that the patient needs to be seen or scheduled for that minor procedure, then it might be appropriate to bill that as a telemedicine visit, because according to the OIG work plan and according to the Medicare manual, if the patient's coming in with the possibility of getting that on the same date as their E&M encounter, which of course, patients expect that to save time, then it's not going to be payable. And if you do get paid, you could be on the watch list and you could be asked for a refund. So something to consider there when you're dealing with those two services on the same day. Watch those minor procedures. Those are becoming a problem. Question number 6 is about the prolonged service code. So it says, Terry, our provider performed an office evaluation and management service for a new patient. It was an extensive encounter, and there was high complexity medical decision making. So it was a 99205, and it lasted about 84 minutes. Can I use the new prolonged service codes to account for the extra time? No. You should report just the 99205, because on a time-based service, that is 60 to 74 minutes of total time. And the descriptor for the new office or outpatient code for prolonged services says that you have to have at least 15 minutes beyond the usual contact of the usual service with the patient. And so the 99417 would not be added unless you were beyond that. So it would have to be beyond the 74 minutes. You were only 10 minutes beyond that, not 15, to be able to code for that. So just be very cautious with that. Now, there are some that are going by the where it just has to be 1 minute, the 60 1 minute after. I'm just not advocating for that. So, Medicare wants you to use their code, which is the G2212, but you have to reach the 15-minute threshold beyond. Otherwise, you are going to get all kinds of audits after that, regardless of what CPT is telling you. I've already seen it, and CPT is going to have to change what they're saying in a certain point. So I'm going to say no on that, that you need to have that 15 minutes beyond. So number 7. So Terry, you've been mentioning that audits have restarted, and I've gotten something in the mail to look at our telehealth visits from January. Do we need to be concerned? So you don't need to be concerned as long as you were audio and video, if you billed for E&M services, that you had a valid consent for the patient, or just a reminder, if you had them signed a year ago, they're expired, so you have to make sure those are re-signed. And then also that you still follow the E&M guidelines when it comes to documentation. And there is a statement in there that the patient knows that they're being billed if their platform that they're using, FaceTime or Skype, is not HIPAA protected, that you informed them of that. And then everything else, in there, that they understand they're going to have an out-of-pocket as well. Some patients are not being told that, and that is a violation of the CMS CARES Act. So make sure that that's in there, otherwise that could be an issue. But number 8 also talks about audits. It says, what other audits are resuming? We're finding that Medicare now is pretending that the pandemic isn't over. Well, they're not pretending. They're just have pushed out a lot of money in the last, let's face it, almost 2 years now. So here's what's going on for September. CMS plans to resume targeted, probed, and educate audits. Those are the TPE audits on September 1st. They suspended them during the COVID-19 pandemic, and they keep saying during. Well, we're still in it until at least October 20th. Now, TPEs are usually conducted by Medicare Administrative Contractors, so the MAC contractors, and are intended to be more instructive than punitive. So what that means, it's different than the RAC audits. They're basically saying, we found something and we want to educate you on why this presents a financial risk to Medicare. And it focuses on services that have a high national error rate risk. And so we have to be careful. What they're looking at for the TPE, from what I'm told, is they're looking at nursing homes first, and then they're going to be looking at certain hospital inpatients for COVID. And so what they're looking at is just seeing it, who overcoded, was the COVID specific to that patient? Did they have it, or were they just diagnosed with it? And was it more contributory, or was that the reason they were in the hospital? So audits can be very time consuming, I know, for providers, especially in terms of personnel work hours. So when selected for a TPE audit, the contractor usually looks at between 20 to 40 records and medical documentation. So just be ready for that. If they ask, do not ignore it, because it is being resumed as of September 1st. Number 8, Terry, we have had patients now asking for us for their records. And we know you talked about the Cures Act not too long ago. How long do we have, and can we just print it to paper and give it to the patient and tell them they can pick it up in 30 days, or what's our option? Okay, so the Cures Act says 15 days, and you have to abide by that. Otherwise, you could be fined up to $1 million. And the new part of that is that you have to deliver the records where the patient asks for it and you have the capability. So if, let's say they have Doxy, which is a medical phone app, and that's how they want you to send it, and you have the ability to send it that way, then you have to send it the way the patient requested. So be aware of whatever they're asking for. If you have the capability to send it through an app that way, then you need to. And please do not blow off these patients or say, pull up your patient portal. You can talk to them and say, that report is in your patient portal. Let me walk you through it. And then let's say they're looking for a path report. And so walk them through it and say, is there anything else you need? Because I want to make sure that you got your record that you're requesting, and then timestamp it, date that conversation, make sure the patient also agrees. And I would actually print that off, send it to the patient as well, and have them sign off on it and send it back. You have to cover yourself on this. Otherwise, you could be in violation. So just make sure you're aware of the new rules with that. Question number 9 is about EEG coding. And actually, it's interesting because it's kind of generic, even though it is neurology. And for patients who have seizures and having those tests to measure that seizure activity. So a physician called me, and actually we were speaking this morning, and he said, I want to purchase an EEG system and machine, and I want to put it in a skilled nursing facility or in an inpatient rehab unit, and I want to build the technical, not just the professional. Can I do that? The answer is no, and that is something you have to be aware of. I had a vascular surgeon try to do that with a Doppler machine before. The problem is that inpatient rehabs and skilled nursing facilities are under Part A. They can choose to purchase this equipment. Most of them do not want to spend the money. So what happens is that if a doctor, and this is in a rural health area, if a doctor wants to have that test done, they actually have to get a mobile unit out there that has these machines, and then they would bill the technical and your physician would bill the professional. So you even though you would own the equipment, you can't bill the global service, or you can't bill the technical because you don't own the facility. So, and it's not part of the Part A package. And so it just becomes a nightmare and you can't do it. So just so you know, you're not helping by doing that. And if you use a facility, or I should say, if you use a service that is a mobile service, make sure, and I also explained this to this doctor just from a compliance standpoint, and especially because he's in a rural area, and he said he's the only neurologist within 100 miles. Make sure you have a good compliance plan, a good system where you explain how your workflow is and your process, because you're going to have inflated numbers and your volume alone is going to look like everybody's getting an EEG when it may be medically necessary, but you also don't want to have financial interest in that company that has the EEGs, because then you're referring to yourself. It just becomes a Stark 2 nightmare. And so just make sure that there is a company that you're not financially tied to, and that way it's a cleaner way to do it. Okay, number 10. This question is kind of interesting because this is where we can get a little confused with sign or symptoms versus chronic conditions when we're looking at the 2021 guidelines for chronic. And doctors always want to go to that level 4, I'm noticing. So the question came from a physician, says, is smoking, like obesity, considered a chronic condition? No. So smoking would actually have to have some kind of smoking condition, so emphysema, etc. And so that is not considered a chronic condition. I know they want to use the smoking cessation code, so you would look into the F codes, which is history of or current, smoker, but it's not a chronic condition. It's actually now an acute symptom for that patient. So you're probably in low unless you relate it to an actual smoking condition where the patient maybe has, lung issues or chronic shortness of breath or COPD, again, emphysema, those kinds of things. That's where your chronic condition would lie from the manifestation of being a smoker. And so just be aware of that. That is not considered a chronic condition by itself, being a smoker. Okay, everyone, it is time for my personal tidbit. So I'm in the middle of my move, and I think Amazon thinks I took out a branch in one of their stores. And one of the things I mentioned before, as far as you can drop things off at Kohl's if you need to return anything. So, for example, I got one extra ceiling fan I didn't need. I had one extra bath, something for my bathroom I didn't need. And so it was so nice, one extra clock to be able to drop it off. And they give you a $5 coupon to use towards anything. But one of the things, make sure you look at those coupons. And I'm not a Kohl's shopper, so I don't even know. They're only good for the day that you return it. How rude is that? So just a little tidbit there. It's not good for, a week or two when you can collect all of them and say, oh, now I'm going back with, $20 in coupons. They don't want you to leave the store. So I just thought I'd throw that out there just so you are aware of that, because you have to read the fine print. And that's what I was doing. And I found out that there was definitely an issue there. All right, everyone. Well, football season's coming up. I'm very excited. I've got 3 fantasy teams I'm on. I got my draft coming up in a week, so hope everyone else is hopeful for that. And if you want to hear about Pittsburgh Steelers, follow my Steel City Underground podcast, WTF, What the Football. That'll start as soon as regular season starts in a couple weeks. All right, everyone, have a great day and a great rest of your week, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.